Thank you, Dr. Crow and Dr. Chen, for the privilege of the podium. So I'm going to talk about things that are troublesome also that we deal with: nutritional deficiencies, hyperinsulinemia, hypoglycemia, enteral access. I do have a couple of videos of nutrient transit through the small bowel. I'm just kidding. I don't have any videos. These are my disclosures. So nutritional deficiencies are common, especially after our malabsorptive procedures. In particular here, I'm talking about the Roux gastric bypass. The RDA we know for different vitamins and nutrients, but we are intentionally causing malabsorption. And so because of that, we are increasing the risk of that we will have nutrient deficiencies. This is a simplified view of the digestive system. It allows you to see very quickly where we are making an impact in the duodenum and the proximal jejunum with our Roux gastric bypass. So multiple minerals and vitamins that are impacted here. The nutritional deficiencies and complications are numerous. So we have mineral deficiencies, zinc is very common, copper, vitamin deficiencies, protein deficiencies, anemias, folate, thiamine, and then the malabsorptive complications you may see, like diarrhea and flatulence, electrolyte abnormalities, neuropathies, bone demineralization, hepatic decomposition, nephrolithiasis, renal failure, and even short gut syndrome. So prevention certainly is adherence to a vitamin regimen, working very closely with dietitians to make sure that we have adherence and regularly scheduled lab work, monitoring our nutrients on a regular schedule. And this gets difficult as time goes on and patients no longer follow up. Monitoring what's happening with the patient, where they are nutritionally, is tough sometimes. You can see that the timing here for the gastric bypass, I typically do every 6 months in the first year, then every 12 months after. And you can see the assessment here: CBC platelets, electrolytes, certain vitamins and minerals that we're looking for. We spent a little bit of time on thiamine because this is one of the more common ones that we see, and it's really a tough one to deal with. I have noticed, and I don't know if anybody in the audience has as well, that in this COVID pandemic, I've seen more thiamine deficiency. And the gastrointestinal complaints that come along with the COVID disease has led to Wernicke's encephalopathy and so on. So this is a deficiency that's secondary to excessive vomiting. It's seen with every bariatric procedure, can lead to significant complications: Wernicke's encephalopathy, peripheral neuropathy, and importantly, these may be irreversible and a cause of malpractice claims. Here are the clinical syndromes of thiamine deficiency: dry beriberi, which is primarily neurologic, so peripheral neuropathies, which may cause numbness, tingling, muscle weakness, extremity pain or tenderness, partial paralysis, loss of tendon reflexes. And then wet beriberi, which is opposite, but is more cardiovascular in nature. So tachycardia, high output cardiac failure, respiratory distress, lower extremity edema, dilated cardiomyopathy, and lactic acidosis. Really, the game here is early prevention, and if we are not preventing, recognizing very early before we get to these things here. Bariatric beriberi is associated with small intestine bacterial overgrowth from the malabsorption that we have created, and is treated with antibiotics to help correct the thiamine deficiency. And then there are gastrointestinal complaints, and then, of course, Wernicke's encephalopathy. So this is opposite from dry beriberi, which is the peripheral nervous system. This is the central nervous system now. It's characterized by ophthalmic complications, ataxia, confusion, may lead to coma and death, and may be permanent. So, we require all of our patients to take vitamin supplementation, including thiamine supplementation. Like I said before, early recognition, early resolution of any complaints is very important. And I really take a lot of time warning my patients to please contact me if they have nausea and vomiting, but contact me if you get diagnosed with COVID is a new thing that I've added, just based on what I'm seeing in my practice. Of course, treatment is to replete the thiamine with a vitamin banana bag, treat the diagnosis, if it's a band, if it's a tight band, if it's a stricture, obstruction. If you can reverse the cause, do so. And then aggressive therapy, removal of the fluid in the band, if it's a band, endoscopic dilation, surgical revision of obstruction. These are guidelines that were published in SWORD a couple years ago, and this was a collaboration between multiple societies involved in the treatment of the patient with obesity. And so you can see that folate deficiency is up to 65% of patients, so very strong prevalence of folate deficiency. And it's very important in patients who are of childbearing age, women of childbearing age, that you keep a close eye on their folate levels. Iron deficiency is very common. We are testing routinely for that. Vitamin D, and this was surprising to me, very, very common, up to 100% of patients. Thiamine deficiencies, which we've talked about, have a high prevalence as well. Vitamin B12 in the Roux gastric bypass is under 20% prevalence. And then vitamin A, up to 70% of patients within 4 years after surgery. And zinc is very, very common as well. Moving on to postprandial hyperinsulinemic hypoglycemia after bariatric surgery. Fortunately, this is pretty rare. It's most commonly associated with the gastric bypass. And screening recommendation is for patients who have hypoglycemia, and this may develop up to several years after surgery. Typically, these patients present with hypoglycemia symptoms 1 to 3 hours after a carbohydrate-rich meal, and they have Whipple's triad for hypoglycemia, which is very important because that's the same triad for an insulinoma. So you need to make sure that you're ruling out an insulinoma with these patients. The etiology is altered nutrient transit, overstimulation of GLP-1, and augmented pancreatic insulin secretion. As we mentioned, they have a higher postprandial insulin, up to 10 times normal concentration, and they typically occurs 2 to 3 hours after eating. There are autonomic symptoms as well as neuroglycopenic symptoms to be aware of. Autonomic symptoms like anxiety, sweating, tremors, palpitations, and then other symptoms of confusion, weakness, lightheadedness, dizziness, and even loss of consciousness in these patients. The symptoms can be progressive, leading to loss of consciousness and coma. As we mentioned before, rule out an insulinoma. And how do we diagnose this? You need to work very closely with your dietitians and endocrinologists for these patients. Have the patient fill out a dietary journal that talks about the onset of symptoms, what foods they had eaten, how long after the meal did they feel the symptoms, do the confirmatory laboratory and provocative testing, and the diagnosis is typically going to occur, the disease typically occurs about a year or more after surgery. Treatment is typically dietary modification. This is usually what works for most patients, putting them on small, frequent meals, high fiber and high protein, low and simple carbohydrates. As I mentioned before, the dietitian is critical, working very closely with the patient, and an endocrinologist as well, especially for patients who are not responding to the dietary modification. Pharmacotherapy has had variable results, and there have been multiple medications that have been tried. Calcium channel blockers, alpha glucosidase inhibitors, potassium channel agonists, GLP-1 receptor antagonists, and even long-acting somatostatin analogs. Most of these work by reducing the insulin secretion, but they are all limited by some adverse effects, lack of efficacy, and cost. Surgical treatments. Gastrostomy tube. This is probably the most common first-line surgical treatment. Placement of the gastrostomy tube allows for nutritional support. So it allows us to feed the patient, make sure that we are meeting their nutritional needs, and it may provide some symptomatic relief. And interestingly, studies have shown that it's actually a positive predictor if the patient does well with the gastrostomy tube, that if you reverse the Roux gastric bypass, they may also do well with that. There have been some small studies looking at gastric outlet restriction. Those have not been favorable. Roux reversal. Again, small series studies looking at reversal of the Roux gastric bypass. It may be technically challenging, and there is certainly potential for morbidity and weight regain. Some studies have shown some short-term benefits, but there has been up to 50% complication rate in the literature. And there have been some cases of recurrent hyperinsulinemic hypoglycemia after Roux gastric bypass reversal. Certainly we need more long-term data. Conversion of the bypass to sleeve. Very few cases have been reported. There has been some short-term resolution of hypoglycemia symptoms without weight regain. It, again, may be technically challenging and also needs further studies. Distal pancreatectomy. So partial pancreatectomy has also been studied. There's more than 50 published cases. Unfortunately, this is not recommended as a treatment option. 25% of patients reported no long-term benefit, and 50% of the operations were deemed unsuccessful. A study by Mathavan looked at 9 patients with hyperinsulinemia, hypoglycemia, and just over 20% had persistent frequent symptoms, and another 20% had severe symptoms of hypoglycemia, which was refractory to medical management. And it's associated with significant potential morbidity, including diabetes, which may have been the reason you did the Roux gastric bypass in the first place. So finally, enteral access. We certainly know that by changing the anatomy, we have now made the gastric remnant and the biliary tree a little bit more difficult to access, but there are ways to do that, and there are reasons that we should. Here are some of the clinical situations. Bleeding in the remnant from your staple lines, which may happen very early after surgery. Acute gastric distension, which may require you to access that so that you can relieve the distension. Leaks, need for enteral feeding access, peptic ulcer disease within the remnant, cancer, and diseases of the biliary tree. This can be accessed in multiple ways. Image-guided, using ultrasound or CT-guided access is possible. Surgical access. This is my preferred method, minimally invasive approach, placement of a trocar into the gastric remnant or a gastrostomy tube as needed for the patient. And then endoscopic access, the double balloon enteroscopy. So using the balloon, as you see here, to maneuver down past the JJ anastomosis and then retrograde up to the remnant. Also can be used for ERCP. Thank you so much.